first of all, why is there a special branch for hand? I mean, why is it not that an orthopedic surgeon or a plastic surgeon or a general surgeon can also take care of these problems? That's simply because if you look at this image, you realize that the hand is not just one or two bones. It's got 5 metacarpals, 5 proximal phalanges, 4 middle phalanges and 5 distal phalanges, 8 carpal bones, ligaments for each one of these, muscles that control each one of these, and even the slightest improper treatment can lead to stiffness, pain, and discomfort. And if you mess it up, then the limb can be completely non-functional, and that is extremely difficult to deal with when you need bimanual skills. So the hand surgeon is expected to have a intricate knowledge of the anatomy in the region, to have specialized surgical training, know a lot about splinting and rehabilitation techniques, etc. And what are the common things that comes to a hand surgeon or into the clinic? Well, mostly they come and tell you that, doc, my hand hurts. So starting with such a generalized idea with so many other joints and bones and tendons involved, what is important is to take a proper history, do a good thorough clinical examination and some investigations to try and find out what the problem is. So when you look at the patient, the first thing that you should do is to try and locate the exact point of the tenderness. So you will know that if it's at this point, it could be a trigger finger. If it's lower down towards the center of the palm, it could be a carpal tunnel syndrome. If there is tenderness at the border of the CMC joint, it could be thumb basal arthritis. If it's proximal to that, chances are that there's a volar wrist ganglion. When you turn the hand around, it could be primary osteoarthritis at the DIP joint. It could be synovitis or rheumatoid arthritis affecting the MP joint or the metacarpophalangeal joint. And near the wrist, at the distal radial styloid area, it could be a Deckard vein stenosynovitis or a dorsal wrist ganglion if it's more toward the center. When you look at it from the radial side, there could be tumors like a glomus tumor, very commonly seen at the base of the nail. It could be nail fold infection, simple infections. It could be basal joint arthritis or Deckard vein. So there's so many things that walk into your clinic that you need to differentiate them, and not all of them are carpal tunnel syndromes. And I see this very commonly, that a lot of us tend to think about any complaint related to being a carpal tunnel syndrome. So here's this patient who came into the clinic and said, doc, I have pain in my palm and at times my finger gets stuck. And this is the video that shows the finger getting stuck, but she's voluntarily able to try and straighten this out. So I'm going to ask Nikita what she would do in such a case.
So like we saw the video, the finger is getting stuck when the patient is trying to extend it, which is called the trigger finger, which is one of the most common infections of the hand we see in our day-to-day practice. So what are the clinical tests that we need to do for a trigger finger? First is tenderness, like any other infection. Where do we look for tenderness? It is at the A1 pulley on the volar side of the palm, which is generally at the distal palmar crease. So along the distal palmar crease, along the midline of the finger is where the tenderness will be, and around the proximal crease of the thumb. So now, when should we get an investigation done in such cases? So if the finger is swollen, which is suggestive of synovitis, if the finger has a flexion contracture and the patient is unable to extend it, which shows that there is a locked trigger finger, the patient is not able to open it voluntarily and needs involuntary help to open it, or if there are multiple fingers involved, which is suggestive of inflammatory arthritis. So what are the investigations that we need to do? Suppose there's a locked trigger finger, then the musculoskeletal ultrasound is one of the best tests to diagnose this. And in case if there are multiple fingers involved or we suspect synovitis, then get an arthritis profile done to rule out any kind of arthritis. Many a times this condition is associated with conditions like hypothyroidism or diabetes. So get a blood workup done to find the blood sugar levels and the thyroid profile. Now, how do we go about treating trigger finger? Suppose it's an early presentation, the patient has a very short history of symptoms. We can treat it initially by elevation to reduce the edema in the fingers or under the A1 pulley. Give them some anti-inflammatory medicines again to reduce edema. Warm water soaks and stretches at least twice or thrice a day. Uh, we can give them some anti-inflammatory gel or cream for the pain, and local ultrasonics by a physiotherapist. Now, what if there is no relief? The second option is a local injection of steroid. Usually we use 40 mg of triamcinolone with 2% of lignocaine. But try to avoid these in diabetics and very elderly patients because of the danger of tendon rupture. And we almost never repeat an injection. So once you're giving the patient an injection, always explain it to them that the results are very unpredictable, that patient might have relief and never get the symptoms back, or might have no relief at all. Now, what do we do if there is no relief with conservative treatment and steroids, and if the finger is locked? So the next step is the surgical release of the A1 pulley of the flexor, which is a permanent solution for this condition. This is usually done under local anesthesia and is done under daycare or a day's admission if the insurance requires it. So what do we do with the surgical release? We basically release the A1 pulley. So the finger is made up of an intricate pulley system, and that's the A1 pulley, which lies just above the metacarpophalangeal joint. So this is the pulley that we release. So the skin incision is a very small transverse incision along the midline of the finger. But we have to be very careful because the very fine neurovascular bundles of the finger lie just adjacent to it on both sides. So we have to take care that we stay in the midline and do not go on the sides. So here is the A1 pulley, like you see in this picture. This pulley is slit in between and we de-roof the pulley. That means we take off a part of the pulley so that there are less recurrences, less fibrosis. But the procedure doesn't end here. The last step is to deliver each tendon, the FDS and the FDP, and to check for the proximal and distal excursions of this tendon. Post-op care, we put a patient in a functional splint, and the patient is encouraged to move his fingers immediately. The stitches come out at 10 days. And like I said, this is a permanent solution for a trigger finger. So now here's a patient who has come to us and says that, Doc, I feel there's a bone growing on the radial border of my wrist and it hurts. And this is how it looks. It is tender and it feels like a bone. So now Dr. Warrior will speak about how you go about managing this case.
This is a very common condition where right on this border, the patient gets pain and swelling. And when they feel it like it's very, very hard. It feels almost like bone. And they say, my bone is growing, doc. And when you touch it, it's extremely tender. So what you're dealing with is, this is right on the radial styloid, is the decurvain stenosing tenovaginitis, which basically means that the tendons in the first extensor compartment, that's the abductor pollicis brevis longus and the extensor pollicis brevis, the two of them go in the first compartment, and that compartment has become tight, and because of which they cannot move the wrist in the ulnar deviation. So opening caps, pulling doors, lifting weights, holding a glass of water for long, change in the position of the wrist, all of that is very uncomfortable, and they come to you with swelling sometimes, with pain sometimes. The Finkelstein test is the one that tells you that this condition exists, for which you need to get the thumb. If you look at me, I haven't put the video there, but if you look at me right now, you'll see that you hold the thumb in, close your fingers, hold the wrist transverse like that, and move towards the ulnar side. So the stretch is on this, and the patient screams in pain. So whenever they do this, you know that the first extensor compartment tendons are entrapped and they are therefore crying. What investigations do you think you need to do? Many patients come in with CTs and MRs and X-rays, etc. They're not useful at all. It's a soft tissue condition. The best investigation is a musculoskeletal ultrasound. And if you have a good sonologist, he can tell you how thick the sheath is. It can tell you how many millimeters thick it is. So you know exactly how it differs from the normal side and whether it is pathological or not. The treatment, like we discussed for the previous condition, is almost the same, that you can give anti-inflammatory medications, local applications, warm water soaps and stretches. So what you do is you make them do the Finkelstein test in warm water. That's therapeutic. If they do it morning and evening, sometimes it stretches out, the swelling goes down, you keep it elevated, ultrasonics, and sometimes the physiotherapist adds manual therapy, and you get good relief from this, which is lasting at times. Steroids can give you some relief. Sometimes it's temporary, but sometimes it's permanent. But be careful in rheumatoid patients, diabetic patients, or patients with a history of a distal radius fracture. There's a chance that the tendon might rub and it might rupture. Remember that there will be some depigmentation, especially with Kenacort, not so much with Depomedrol, but you can get a depigmentation like this. This is temporary. It takes about 5 to 6 months to recover. So when a patient comes back and tells you, doc, look what happened, vitiligo came, it's not vitiligo. It's the steroid that backtracked in your needle and just caused depigmentation of the melanocytes in the skin at that point. So you just have to give it a little time and it just gets back to normal by 4 to 6 months. Decurvance is extremely common in the third trimester of pregnancy, sometimes bilateral, sometimes during breastfeeding. So you can tell the patient that when the hormonal changes in the body get back to normal after the breastfeeding is over, it might become all right. So you do conservative treatment for them. But you can't give them too many drugs at this time. So you might want to inject such patients at this time. If it still doesn't get relieved and they need to take care of their babies, then definitely you will consider surgery at that.